Sponsor, Diagnostics Direct, Jeff Tobias.
Oh my gosh, how are we doing today? Come on, I heard you guys yesterday. How are we doing? All right, thank you. So I can't see you, so I can't picture you in your underwear right now. But anyway, on behalf of Diagnostics Direct, I would like to welcome you to today's panel session on Doxy PEP and the potential issues that may rise in the STD field. Put together a great panel today, and we also have a great moderator. This is going to be very interesting. You're going to love it. For those of you who don't know who I am, you just heard I'm Jeff Tobias. I'm the Vice President of Diagnostics Direct. I'm also one of the co-founders, and we're very proud to be a sponsor today. We're very happy to be here. You may also know us, you've seen our logo around. You may know us more as the Syphilis Health Check test. If you can believe it or not, Syphilis Health Check has been around for over a decade now. And we've put millions and millions of tests out into the medical community in just about every type of medical facility that would use a rapid test. So we're very happy with the test. Additionally, through all that time, we've had a great relationship with NCSD and all of you guys here in the room. I remember my first Engage. We were sitting yesterday and I was listening to everybody reminisce about Engages years past. Our first Engage was 17. We had very little budget. We just got a booth. None of you knew who we were. I spent all day introducing myself, telling you about our little test. Fast forward, here we are, 2023, double the size of the Engage. Diagnostics has also doubled in size. I walk around yesterday and today, and everyone's coming up. Hey, Jeff, it's finally great to meet you. All you that I talk to on the phone, everyone that I email regularly, it's so great to see you in person. Couldn't be more excited about the test. Also love hearing all of the users, all of you frontline users that use the test. You come by the booth and you tell me how great the test is. We know that this test is having an impact in your community. It's improving your ability to treat your patients. We love hearing the stories. Jeff, it's so easy to use. Jeff, it's so flexible. I can use it in the office. I can use it in the field. I can use it in a mobile setting. So we love hearing those stories. Please keep coming by the booth because, like I said, we'd love to hear it. Look, we started this company in 2010. I've sold every type of gadget you can imagine. But this is an opportunity. As a company, we want to do well. But with this test, we're also a company that's able to do some good. And so the sales guy in me wants to pitch your product right now. I'm itching to sell. I know there are people in this room not using our test. So if you're here, please come check us out. We're in booth 200 right outside the door. We'd love to talk to you. If you think you've got red tape and obstacles that isn't going to work to make a change, just remember, we've worked with governments, the military, state public health departments at the state level, probably 40 of them, and every other type of organization to get this test into your protocol. So there's not a problem that you're facing that we probably haven't seen yet. So please use us as a resource. We'd love to work with you. I'd like to be up here in 24 with my rum drink in hand in the Virgin Islands with all of you guys as customers. So record it. Next year when I have my rum drink, you guys will know that everyone here is customer. And again, we really value you guys as customers. We value our relationship with the NCSD. This has been a phenomenal show. David, I don't know how you top this next year without going to the Virgin Islands. So I'm going to say it 3 more times. I think we're going to the Virgin Islands next year. So no. So anyway, we have a great session coming up. You met her yesterday, Michelle Allen. She's a great moderator. She's going to take it from here, and we're going to talk about Doxy PEP. Thank you, everybody.
Good afternoon, everybody. Are you enjoying the conference? Are you enjoying your meal? All right, one more time for the sponsor. So my name is Michelle Allen, just like yesterday. I didn't change it. I hail from the great state of Georgia. I am currently serving Positive Impact Health Centers as the Research and Development Institute Director. So one time for your nonprofit partners. All right, for a group of people who knows the importance of prevention, who says things like prevention is a cure, aren't you excited to be in a plenary where we're going to talk about a biomedical intervention? I want you to take advantage of the subject matter experts that will be before you. The panel will come out and they will give engaging comments. I am going to solicit feedback and interaction from the audience. So are y'all ready? All right, so on 1, 2, 3, we're gonna make a bunch of noise and bring this panel out in grand fashion. 1, 2, 3. Let's make some noise. Come on out, panel. Woo! So as I said earlier, my name is Oprah Winfrey. I would like to ask all the panelists if they could introduce themselves and introduce their roles, and we'll get started.
My name is Jeff Klausner. I'm a professor of medicine, infectious diseases, and public health at the University of Southern California, and really excited to be here today. I want to know, is anyone here from San Francisco Department of Public Health?
Here they are.
There's a couple of woo-woos. All right. So people may know I've been the STD director in San Francisco from 1998 to 2009, and the president of the State of California STD Controllers Association. So you people are my people, and I'm happy to be here. Thank you.
Thank you.
Good afternoon. Oh, I'm supposed to say. Good afternoon, everyone. I'm Jason Henry from the U.S. Virgin Islands. All right. I'm the director for the Communicable Disease Division in the Virgin Islands. What's unique about our division, we have STD, HIV, TB, and also our Ryan White program and surveillance. And so it's like, so the Communicable Disease Division has it all. And definitely excited to be here and looking forward to have some good discussion. Thank you.
Hi everyone, I'm Shira. I'm the medical director of the Detroit Public Health STD Clinic.
Hi, I'm Andrew Yu, pronouns are he, him. I work for the Indian Health Service headquarters. I'm the national, I am the National Clinical Coordinator for our HIV Hep C STI program. Prior to joining IHS, I worked as a nurse clinician at New York Presbyterian's HIV clinic in New York City.
Okay, so before I get into the book of the month, we're going to talk to the panelists. And one thing that I said earlier before you all came out is you are the experts. Like, if you are a student of this field, then these are names that you know, spaces you have shared. And so I am sitting next to the iconic Dr. Klausner. And I want to start with you, your emerging research on Doxy PEP. Please tell us what we know right now, and I would also like for you to get into what we don't know.
Sure. So I don't know how far we want to go back, Michelle, but you know, I do want to share that the idea of Doxy PEP was first put in front of me in about 2004. So 2004, we were doing very well in San Francisco. We had just, we're in our third year of our Healthy Penis campaign.
Yes.
One of the most successful sexual health campaigns the United States has ever seen. Syphilis rates were coming down, actually. But at that time, as people know in this field, when rates come down, funding comes down. So we're starting to see a decrease in funding. And by the end of that year, we're starting to see an uptick. And I asked one of my senior D, I asked one of the managers, Giuliano Neri, you know, what he thought and how he protected himself in the 70s and 80s. He said, hey, you know, Dr. K, actually on Friday night, I always took vibramycin. I said, vibramycin, that's doxycycline. He goes, yeah, it was very common. We would just, you know, take doxycycline on the weekend before we went out. And he goes, I never got an STI. And I was like, wow. You know, we prescribe doxycycline to people who are going traveling for malaria prevention. We use doxycycline for Lyme disease prophylaxis if someone has a tick. The U.S. military uses doxycycline among people who are deployed to tropical areas to prevent leptospirosis. Doxycycline is used as a prevention for travelers' diarrhea. It's recommended by an infectious disease society. People are on doxycycline for months and years for acne management. I'm like, you know, this really makes me think, you know, how can we use doxycycline as an STI prevention tool? So unfortunately, we had proposed some studies at the time to the NIH, and the NIH didn't prioritize it as much as we thought we should. And then I left San Francisco and I went to South Africa. But this was also always kind of percolating in the back of my mind that we needed to do a study to figure out, could doxycycline really work to prevent STIs? So when I came back from South Africa in 2011, I reached out to Bob Boland at the Los Angeles Gay and Lesbian Center. And I said, Bob, let's do this study. Let's do a small study and see, one, you know, can people safely take doxycycline? Two, if they take it, will it prevent STIs? So in 2011, we launched the first randomized controlled trial to see if doxycycline worked. We enrolled 30 people, 30 men living with HIV. And sure enough, the people on the doxycycline arm had a 72% reduction in chlamydia, gonorrhea, and syphilis. And that really was the first study that showed us that this, you know, possibly could work. And then the French went on in Paris. They replicated the study. Instead of using it every day, they had men take it after sex within 72 hours, like PEP. So PrEP, pre-exposure prophylaxis, is every day. PEP is after a sexual contact. And that worked as well with the same 72% effect. And then finally, the studies were again replicated in the United States by folks in San Francisco and the University of Washington and Seattle with the same about 65 to 75% effect. So one thing we know for sure is that Doxy PEP works. So we don't really need any more research, at least in males, to show it works. People may be familiar with a study that came out of Kenya, which showed that it probably didn't work in cisgender women. We need to do more work to understand why and replicate and do those studies probably again. So we don't need more research that it works in people born male. It definitely works. Now, concerns you asked me, I think, about are, you know, one, are there side effects? So with taking long-term doxycycline, we do know that there's what we call photosensitivity. So people out in the sun can be more likely to have a sunburn. So we just inform people about that potential side effect. Some people can have an upset stomach. There are different formulations of doxycycline. Some are more or less associated with upset stomachs. If you take it with food, it seems to help prevent that upset stomach. The third side effect is that if you take it right before bed and you're lying down, and if it gets caught in your throat, it can be erosive and cause an ulcer in the food pipe. So that's a concern, and we typically tell people don't take it right before bed and drink a glass of water, you know, when you do take it. So there's practical things we can do to reduce that. So those are the main things you're concerned about in patients. And then lastly, you know, the bigger concern on the public health level, which, you know, we need to be aware about and recognize, is the, you know, issue of antimicrobial resistance, right? So antimicrobial resistance, it's, you know, up there with the big threats that we see, you know, whether it be climate change, new pandemics. Antimicrobial resistance means that there'll be, you know, other germs out there that we can't treat with our current antibiotics, and we certainly don't want to contribute to that. But fortunately, and for reasons we don't fully understand, syphilis has never become resistant to penicillin. So we've been using penicillin to treat syphilis since 1943. So in 80 years, syphilis has not become resistant to penicillin. Similarly, it's not become resistant to tetracycline or doxycycline. Chlamydia never become resistant to doxycycline. And gonorrhea, yes, there is concern that we could develop resistance of doxycycline in terms of gonorrhea treatment, but that's not what we use for treatment. So to me, it's important to monitor, but it should not be a barrier to our implementation, and we can still monitor and make sure we're not causing harm at the larger, level of community and population health.
Okay, thank you, thank you. So now I want to continue, and I would like to go to you, Dr. Heisler. Tell me what your experience has been in the Detroit Public Health STD Clinic.
So we have implemented Doxy PEP, which has been, we started it actually right after CROI, when new data officially came out, so like end of February, and I actually just looked today at the data. We have about 50 patients on it. So the uptake is really great. Something that I want to point out is that working in a city like Detroit, which is around 88 to 90% Black, we all know that STIs, all STIs, disproportionately affect men having sex with men, and in particular, men having sex with men of color. And so one thing that I think Doxy PEP is going to do if we implement it, and we need guidelines out, there's no official guidelines out, CDC has not come out with anything yet, is that if we get this out in guidelines and we start showing how easy it can be to implement, we can just roll this up with a prep visit. And doxycycline is cheap. Also, for our uninsured patients, the state health department who funds our clinic and funds our medications gave us pills of 30 doses. So I really believe that implementing this is practically quite easy. And I think it could be a key to truly minimizing the racial disparities we see in STIs.
And I think that as we continue to have conversations around health equity, that last point did not go unnoticed for me. So you think about how we get it out, how we advertise, how we let patients know, and even how we prioritize how it's being offered in clinical settings. Andrew, I feel like it's a natural segue to go to you.
Yeah, so at IHS, we're in the planning stages of implementation. There is a lot of interest in Doxy PEP. And so part of that planning right now is to bring more awareness and education to both providers and patients that this intervention exists. I think of who's in the room right here, and we are all aware of Doxy PEP, but I think of the people who are not in this room. And this goes beyond Doxy PEP. It's with HIV PrEP, it's with sexual health care in general, that we need to do a lot more training and education as to what this intervention is and how it can definitely help a lot of people.
Okay, so yesterday, Jason was telling us everybody in the Virgin Islands is a virgin. And so I know that as you sit in this seat as an STD director, your lens may be a little bit different. So I would love to hear from you at this time.
Sure. So, like you said, we don't need Doxy PEP in the islands because we're all virgins. But I don't think we're going to have enough sunblock to fit on the shelves, though. Right.
Duly noted for the panel.
That's right. But one of the challenges that we see implemented in the islands is not only from the public health standpoint, but from a community standpoint. Being in a small rural community, we're going to have challenges. When you have churches who are not friendly of the LGBT community, when we have other populations not friendly of the LGBT community, and as public health individuals that is put in Doxy PEP and is primarily for our LGBT community, like, oh, you're promoting this, and then so how do we work and create buy-in from those individuals? How do we address a church when the church is, well, nobody in my church has sex, or nobody in my church has sex out of marriage, and so those are some of the things that we're going to face. Also, in the Virgin Islands, we have actually one chain pharmacy, but that is on St. Thomas, and then so how can clients actually access the medication who are on St. John, who are on St. Thomas, or who's on Water Island? Like St. John has a population of 5,000. Water Island is like 100 individuals. So how do we have access to the medication? And then what is the cost? Yes, it's not expensive, but then when you're in a small community, that is one of the issues. And then when someone is going into the pharmacy, the stigma, oops, the person who's providing services to you knows you. And so those are going to be some of the challenges that we face as we work towards implementation.
So I'm going to do another round of comments from the panel before I go to the studio audience. And if you've ever watched Oprah, you know when I come to the studio audience, you're going to have to participate. So get ready, right? But one thing that I would like to do before we go to the panelists is to think about the themes that are coming up, right? Access to care, health equity, insurance. These are all things that, honestly, think about, if we tackle once, we shouldn't have to tackle them again. Think about what was said earlier about how we treat malaria. Are we still fighting malaria the same way we were previously fighting it? Once we find things that work, we need to share. Access to care may be also something that those of us who are in rural areas can relate to, or feeling like someone knows you when you go in for service. So these are things I want you to think about as I prepare to come to you, and I'm coming. All right. So now we brought up the points and the intersection, and now I want to think about what we learned from monkeypox, or what we should have learned, and what we may be repeating, right? So we saw an early awareness and an uptake, particularly among white gay men. We also seen the same thing happen with HIV PrEP. So how are we going to navigate access and equity as we roll this out? We're going to have to think about it. I'm going to start with you, Dr. Heisler, because I felt like you introduced the thought in your first comments.
Yeah, so thank you for that question. I think that this is really important. I think something that we saw in monkeypox was, it kind of came out of nowhere, and then the vaccines come out, and what happened in the city of Detroit, which I know has happened in many other cities, was that white gay men knew about it, they knew where to get it, they knew where to get treatment, and the black community was not in that position. I am seeing that already with Doxy PEP because it's in newspapers. It's in the study, after Croy, it comes out. This works 60 to 70%. And I'm realizing that when I bring it up to my patients, all my patients that are predominantly black don't know about it. And all, white gay patients know about it and are asking for it. And so this is a clue to me that we need to get ahead of this. As I said earlier, we need to come out with guidelines. We need to have something backing us up to say, you guys, we all see the evidence, now we're putting it in guidelines so all providers, rural, small, community clinics can know about it. And I really feel that we need, as a community, we need to offer this to all of our patients so we cannot create the same mistakes as we saw with MPOX and as we're seeing with PrEP as well.
I hear the round of applause. It's okay. We know you're out there. Andrew, I feel it's natural. I'm already looking in that direction.
Yeah, of course. So obviously, I work for a federal healthcare system that serves the American Indian and Alaska Native population. And the organization is waiting on CDC to publish guidelines in order for us to move forward. However, until that happens, we are doing that legwork right now so that once CDC does publish guidelines, we can offer Doxy PEP that same day.
So just taking executive liberty to share what's going on in the health centers I'm affiliated with. We have already set out our protocols and we're looking to roll it out this month. We did look at a lot of stuff that we learned from you all in San Francisco. So as you think about this question in health equity, how would you respond, Dr. Foster?
Well, my first response, I would not sit back and wait for CDC guidelines. I think, CDC had plenty of heads up. The first, announcement that this working was July last year. It is May. It is 10 months later. The people cannot wait for the CDC, and that's what happened in Alameda County, in San Francisco, in Detroit. The state of California, which has never been known to be a fast-acting, public health agency, issued guidelines to the entire state. So I think, the idea that we have to wait for CDC guidelines, I think that's a major disservice to the people that we're trying to help. And I think that the key, obvious to me, is to work closely with community-based organizations that particularly for certain populations, it's really the CBOs that have the trust, that have the engagement with the different populations, and part of that is bringing the CBOs together in your community, providing them the information, the studies, the experience, the guidelines from other organizations, and helping them get the word out to the people that they serve. And then thirdly, because it is so effective for syphilis in particular, and syphilis is really what we're most concerned about, right? Because syphilis on a repeated basis, or syphilis if it goes untreated, has the most serious complications. So with every syphilis test that people get, in every venue, every clinic, every setting, people should be informed, hey, you're getting tested for syphilis. Did you know there's a way to prevent syphilis? That if you're in this certain group, you're going to benefit from knowing about doxycycline. And with every syphilis test should be a fact sheet about the potential benefits of doxycycline PEP for the prevention of syphilis.
So speaking of syphilis, some of you may or may not know that I own and walk in pride and confidence of being known as Syphilis Girl. And one thing, and you say, Michelle, you're older now, syphilis woman. One thing that we want to think about, we think about what Mr. Phillips said to us yesterday, syndemics. Is it possible to end an HIV epidemic without addressing the syphilis epidemic? I think we all know it's not. So think about not just holistic care, but also resources and opportunities to address clients who we know are not only living with competing priorities, but battling comorbidities that we see all the time. I think we should clap. People could be following us online, and this proves we're having a good time, right? Okay, so thinking about what you said, Jason, and this small everybody knows me, and you have some unique challenges that others who may not have the beauty of the islands, but in small communities can certainly relate to. What would you like to share about how you could possibly look at making things equitable?
Sure. So what's unique about that is that as public health providers, you keep hearing me saying this, we have to stop thinking that we know what the people want. We have to go out to them and say, what do you need? We had that challenge with monkeypox, and we went and we created priority grids, and we were like, okay, this population was going to be the first priority population to get access to the vaccine. And yes, we identified the men who have sex with men as the priority population number one. We identified sex workers, and guess what? They did not come, because we assumed that this was going to be the first population that was going to come. But again, here it is, we had something that was also labeling and identifying that population. How do we make it inclusive? And we need to start looking at, okay, how do we make it access for everyone and not say, okay, this is just for this population, this is just for that population. But we need to make sure that, you know what, everyone has access to it. So if you're an MSM, if you're a transgender, whatever it is, you know that, hey, a pregnant, well, not a pregnant woman, but you know that a female, whoever, could have access to the same thing. So when you're walking into that provider to get that service, it's not like, I wonder if that person, because that's what the person who's receiving the service is thinking, like, what are they thinking about me when I come for this service? And so we got to make sure that we're inclusive of everyone.
I think we can. So I think that you now know that you are listening to experts in the field. And I would love to take the opportunity for you all to move to the mic and ask questions or share comments from what has been said so far. Will there be one? Yes.
Hi there. My name is Cameron. I'm with U equals U+. We're the national leader helping folks get word about U equals U out to communities. One of the concerns or things that I've heard with U equals U is a lot of provider bias, and people don't want to tell their patients about U equals U because they would be concerned about it would be a license for condomless sex. Not ignoring all of the amazing other benefits of U equals U, they would say that's the reason I don't want to tell people. For Doxy PEP, anecdotally, I've heard from some of my friends who have asked their providers to prescribe them Doxy PEP that they say, oh, we don't want to do that because we're worried about the antimicrobial resistance. And I am concerned that that's a way that sex negativity is showing up from providers, that they're saying, oh, well, we can provide Doxy for people for acne, but we don't want to do it for sex because sex is bad. So what are your thoughts about how we can combat provider bias? What are ways we can make sure that that's not preventing people from accessing this? Thanks.
That's a very rich question, and thank you for that question. I would like to know if there's multiple people. I think at least 2 of you can respond to that.
Sure, I'm happy to start. I mean, for me, the simple and somewhat glib answer is switch providers, right? So if that provider,
Permission to clap?
if that provider is not meeting you where you're at and where you need to be, you need to find another provider. But arguably that's not easy. So and often you have a relationship that you built up with that provider over a long time, and there are other things you like about the provider. So I think it's important to be honest with that provider, which takes a sense of empowerment to be able to feel comfortable telling that provider, well, you're not listening to me, you're not hearing my needs, and I need you to think about why that's the case. Are you, what are you concerned about? So it often takes more time, but I would challenge patients to try to engage on a more equitable platform with that provider and try to understand the provider's concerns.
I want to respond to that. In some places you can switch providers, and I know it was a joke, but in the islands you can't because you're limited, and so we have to create buy-in. We have to get buy-in, and sometimes you have to show them what's in it for them, what is the benefits, and it's going to take a very long time to actually get buy-in from everyone. We just have to keep advocating for them to understand what is the true benefit of this process, because we in the islands, we're limited with providers, we're limited with resources, and so if you don't have buy-in from the providers, you can't. We have men who are not, I would say a large portion of our men are not accessing healthcare in the islands already because it's just a man thing, like I don't need to see a doctor. I'm good. I'm going to drink my bush. I'm going to smoke my weed, But realistically, we cannot just do that, and so we have to get buy-in from everyone and just continue giving our voice out there.
Thank you. And thank you for your question.
Hi, I'm Brian Collins. I'm with the Virginia Department of Health. I wanted to speak back to the concern about stigma at the pharmacy level that Mr. Henry commented on. So after I heard about the study data, went to my PrEP prescriber and showed her the efficacy data and the guidance that's on CDC's website and asked if she would prescribe Doxy PEP to me. And so she said yes. And so I went to go pick it up from the pharmacy, and it had been sent to the pharmacy as a single dose with 11 refills. And so I asked the pharmacy, isn't that unusual? And they said, well, what did they prescribe it to you for? Which is not a question that I would get with any other medication, but it's off-label and being sent to the pharmacy in a way that's non-standard, I guess is my feeling about it. So I think my question to the panel would be like, what kind of thoughts do you have for how we can work with our own providers that might be willing but kind of unclear, because this is a different situation than PEP for HIV, about the dispensing situation, and what kind of work can we do with our pharmacy partners to make sure that at the kind of ground level that's being rolled out in a way that's not stigmatizing?
So I can answer that. So I think that's a great question. So something that I think is really helpful is in my protocol that was based off San Francisco, kind of anybody who's doing Doxy PEP is kind of doing the same thing. So what we do, and this is why it would be helpful to have some guidelines to give to people, is that we do 30 doses with 2 refills. We also did contact the main pharmacies that we usually use and let them know. And so it's like take 2 pills as needed, and then with 2 refills, and then they come back every 3 months. So I think letting pharmacies know, I think, is a really important thing, and just letting providers know how to prescribe it. And what do you do, having protocols that say, what do you do if you have somebody on Doxy PEP and they come into a contact and they're exposed, right? There's certain nuances that I think overwhelm providers, and that if they just got the information, which isn't that complex, people would be doing it more. So I really think it's like actually getting a relatively simple protocol out there.
And and I know sometimes when I speak, it sounds like, okay, things are always challenging in the Virgin Islands. So the rebuttal to that is, because we're small, we have a limited amount of pharmacies, and I think we have great communication and great, actually, relationships with our pharmacies. So actually, that's one thing you can do, actually have a meeting with all your pharmacists and say, hey, like, listen, this is what's going on, this is what you should be doing, and so on. So that's the one actually advantage that we have being a small community, that we could have a dinner meeting, a lunch meeting, and actually just have a round table and have a discussion as to how to make this more feasible and how to make it that when clients are accessing your services, that they're not uncomfortable.
Thank you for that. I'm going to go here.
Hi, my name is Chase. I'm a DIS at the Red Door Clinic in Minneapolis. My question is about syphilis titers. We know that incidental antibiotic use sometimes squashes titers and can kind of confuse whether someone has new infection or this is just showing old infection. How does Doxy PEP influence how we read titers? And do we have any guidance or answers about that?
So I'll give an attempt to answer that. So, I mean, I would not expect, the antibiotics to affect how we interpret the titers, right? So if someone has a fourfold increase in titer, we're going to consider that a new infection. If they have a fourfold decline in titers, we're going to consider that a response to treatment. There is a possibility, I think, as you're suggesting, someone could be partially treated, but if they were partially or inadequately treated, we would expect a further increase in titers. So I would recommend, I haven't kind of fleshed this out with Leandro or the other CDC colleagues yet, but that there's no change in how we interpret the titers. I mean, people have lots of incidental antibiotic use for other conditions. They may, use amoxicillin or other kinds of drugs that can affect syphilis or syphilis treatment. We often thought that actually some of our control of syphilis historically was because of the widespread use of antibiotics after the 1950s. That because a lot of people inadvertently got treated with these types of antibiotics that actually provided success there. So I think it's a good open question, and I expect guidance might tell us that we will not affect how we interpret those titers.
Chase, where did you go? Okay, there you are. So I don't have a comment to your question, but I have a comment around it. So where I think it's tricky for syphilis is that we don't always talk about things that we do to prevent and control. So a lot of people use reactor grids. Y'all remember those? So we used to say that something was administratively closed based on the age and the titer. And that doesn't mean it wasn't syphilis. It meant from a place of resources, we thought it had the opportunity to be less of an opportunity than going after someone that we actually knew to be infectious. So what's tricky is that when I first started, I didn't understand that it was resource driven. And I really thought it was speaking to not being infected. So where we've been talking about equity, I think training and education is also a part of that conversation. Because if the thought is, this is a 1 to 4, we can close it, and then they come back later as a 1 to 32 because we didn't do anything with it, then we have to think about what that means, and if we looked into other things like method of case detection and the site that the screening came from. Does that make sense? Okay, we can talk more after this, but I just got, caught up in the syphilitic moment.
Thank you, Michelle. My name is Jim Pickett. I'm an advocate from Chicago. And I, about 25 years ago, was known as the syphilis guy, so I kind of feel you.
Yes.
It's just nice to be remembered. I have 2 quick questions. One, do we have adolescent data? And if not, when is it coming, or are there plans to get adolescent data? And 2, for the Detroit or Michigan and Detroit and California that's already rolling this out, what are some top-line sort of comms messages or social marketing that you're doing, or social marketing messages that you're doing to help get the word out, so it's not just about the people who are in front of you, but people out in the community to get the message. Thank you.
Clearly, we're connected. That's actually one of my questions. Thank you, syphilis guy.
All right.
So what we're doing, clearly this is new. We just started rolling it out, 2.5 months ago. We have not, I'm meeting with other health departments, so in the state of Michigan, to let them know what the protocols are, what are the concerns, and how to address them. We have not done a marketing campaign yet, but I personally think we totally should. And I think, kind of back to one of the earlier questions, we need a good answer to this antimicrobial resistance question. And I think it is okay to say, we don't know, but we have used doxycycline for multiple other things. And I think that specifically now being like, well, we're not going to do it because of antimicrobial resistance when it specifically is relating to STIs is like a good time to call up, like, this is what stigma is. This is what bias is. And so I think these are moments that, like, we need to acknowledge resistance, antimicrobial resistance is a big problem, but the hope is also that if we do this, it will minimize STIs so we don't use a full week of doxycycline. So I think that, like, there are actual realistic things that if we touch them, if we talk about them directly, it will also allow providers in the community to be aware of it and be more prone to give it and dispense it.
I felt you guys wanted to clap.
Yeah, and I just want to comment that most of the rollouts now are, implementing in the clinical context. So most of the guidelines now say it is someone, with a prior STD diagnosis, a prior bacterial STD diagnosis. In our first study, it was in, study participants who had 2 or more prior cases of syphilis. So the current implementation is within a clinical context of people who get a new STD diagnosis and counseling intervention to be made aware that in addition to condom use, in addition to partner reduction, in addition to regular STI checkups, here's another way that you can have agency to prevent new bacterial STDs. And I think for me, it's really about giving individuals the agency and the choices to be able to protect themselves from new infections.
I just want to make a quick comment on what Dr. Heisler, sorry?
I am not aware of adolescent trials currently. I'm not.
Yeah, so biologically, there's no reason to think that it would have different efficacy or effectiveness in, younger male adolescents. We don't really necessarily always, the FDA, when it looks at approval, can kind of infer that it's going to work in certain populations based on similar anatomy, biology. So I'm not sure we necessarily need, the San Francisco University Washington trial probably went down to 18. And is there a difference between, 17 or 16? I would not expect there to be. But it's an open question, and adolescent medicine providers, may want to see more, more data. But again, in the clinical setting, it's going to be between the client and the clinician or the counselor to determine what's, a good option for them. And this is a great tool. It's not for everyone, and I've been personally prescribing in my HIV practice for about 5 years, and it's really been helpful for some people to keep them STD free.
I just wanted to make one point regarding Dr. Heisler's comment about how Doxy PEP can lead to overall less use of antibiotics. Right now, chlamydia treatment is 14 pills of Doxy total. We now have a bicillin shortage nationwide that is not going to be resolved anytime soon. So now for syphilis, we're using 28 pills of Doxy to treat primary, secondary, early latent, 48 pills to treat late latent. And so there is a significant difference in the pill burden and the use of antibiotics with Doxy PEP that needs to be talked about more.
That was a great point. Thank you so much for that. I keep looking over here to make sure I'm not missing anybody. Please come forward.
Hi, thank you for presenting today. I really appreciate everything. And I think that you got the buy-in of everyone in the room. But coming from an LHD and knowing that there's big policies and little policies, yay, Policy Academy, when we're looking at implementing things in a local health department, my ask would be, can you share some of the ways that you've already implemented this? Because when, Andrew, you're talking about legwork, I'm thinking of all the legwork it would require for us who have extremely limited resources and a non-clinical background. And if it's already something that's happening, is there a way that you can share that with us sooner? Because as we know, the CDC may come out with guidelines, who knows when they're coming. And I think that we all know this is something that we should get out there sooner rather than later. So I just wanted to ask if that's something you think would be feasible.
I think it's a great request. There's no reason why NCSD, cannot take these California Department of Public Health guidelines, which got shared with every licensed physician in the state of California last week, Alameda County guidelines, San Francisco Department of Public Health guidelines, the guidelines from Michigan or Detroit, and share them. So NCSD has kind of weekly news bulletins that they do a great job of promoting new information to members. So I would recommend that NCSD immediately puts these guidelines on their websites, and then local jurisdictions can adopt and modify as appropriate.
Thank you.
Yeah.
I'm Karen. I'm a nurse practitioner, and I definitely want to get this rolled out to my PrEP patients within the next couple of months. But I just had a question. It's not 100% effective, meaning that is it going to delay, if someone were to have gonorrhea or chlamydia, is it going to delay that diagnosis because of the Doxy PrEP or Doxy PEP? And would you bring them back sooner to screen, maybe 1 month versus 3 months that I do right now?
So I would not bring them back sooner. I think that will, first of all, it will deter people from coming, and we want people to actually take it and kind of buy in. It shouldn't affect, taking these doses really shouldn't affect the actual test. So there shouldn't be a concern there.
Okay. And is there a limit as to how often someone should be taking this?
Once a day. They can only take a dose a day, but in theory, if they're having sex and they got a good sex life, they can take it every day.
Okay, just wanted to make sure, because I know it's, it's within 72 hours, so I didn't know if it would maybe be 2 doses a week, or if it was safe to take 200 milligrams daily.
You can, okay. And I do want to, when we are talking to patients, to really kind of stress the time frame is 72 hours, but the ideal is within 24 hours. So the timing is very relevant.
Thank you very much for answering my questions. I'm really excited and
awesome
to get this started.
Don't leave yet. Please introduce your role again.
I'm a nurse practitioner, and I work at a local health department in Greensboro, North Carolina. And I work in the STI clinic, but then I also prescribe PrEP to about 100 men.
Awesome.
So if you are a nurse or a nurse practitioner and you're in the room, stand up. Thank you for your service.
Yes.
Hi, everybody. Zant Bryan from Washington State. Number one, I want to thank you as doctors for listening to community members to bring this forward. I think something that sometimes is missing from our field is that we don't listen to our communities and trust them as keepers of knowledge and expertise. So thank you for doing that. Those of you who know me, I came for the HIV, I stayed for the syphilis. I'm also originally from Texas. And so I used to live pretty close to the border, and we used to do things like this as community members. I've done this where I had symptoms of something, and I walked across the border to a farmacia, and I bought it, and I used it with some knowledge and some information. So if we think about access and equity, one of the things I'm thinking about regulatorily is when we're talking about moving things into patients' hands, into community members' hands, how do we take as many people and access points or choke points out of the equation as possible? If we're talking about, for example, moving birth control to an over-the-counter type of thing? How do we move something like Doxy to an over-the-counter type of thing to empower community members with knowledge and access all of their own so that none of us are required for community members to take care of themselves? How possible do you think that is, and what are your thoughts on that feasibility?
I don't know the actual process of making that possible. I mean, obviously, we would love to have this over the counter. We would love to have PrEP over the counter, right? We have tenofovir being studied. I would love that to be over the counter. But I did go to Mexico a couple months ago on vacation. I'm glad you brought that up. And I'm speaking as Andrew, the private citizen, not Andrew IHS. I was in Puerto Vallarta. It's a very popular vacation destination for gay men. And almost everyone I spoke to, and I spoke with a lot of people, were using Doxy PEP, and they got it from the pharmacy in Puerto Vallarta because they couldn't access it from their providers back home. And that to me says a lot about what's going on right now, right? People all are aware of Doxy PEP, and because they can't get it from their providers, they're getting it elsewhere. And we need to do better at meeting people where they're at. We always say this at conferences, meet people where they're at, and this is the reality right now. It's out there, and we need to do better.
Right, and that's an equity gap, because anybody who's there in Mexico getting it has money to get there.
Right.
Yeah.
Exactly.
Yeah, so I think in today's environment, we're facing strong headwinds against making things like antibiotics over the counter, right? So the community, whether it be the infectious disease community and other kind of, guardians of antibiotics have said, we got to make antibiotics harder to prescribe, less available. We're facing a crisis of antimicrobial resistance. Every week, people are lobbying, Congress to invest against the fight against antimicrobial resistance, and that actually was one of the reasons why in 2008 the NIH defunded the first large study of this. They said we are too worried, and the context and the timing is wrong to be talking about prophylactic antibiotics. So I think for now it's going to take these community type actions, and people going to Mexico, buying large bottles of 500 capsules, and sharing it at the white party and sharing it at other events, and people using their social and sexual networks, which we do know is a great way to spread information and provide access. I mean, things can become over the counter. There was a push, people may or may not know, for acyclovir, right, the medication for herpes, to be over the counter. And the manufacturer had to present data to the FDA saying that people could use it correctly, people could use it safely. So it requires a manufacturer sponsor. And because these are generic and inexpensive, unlikely that there's a business opportunity for a manufacturer to bring it over the counter. But there can be continued awareness and advocacy to try in that direction.
Thank you. I just want us to acknowledge, though, that regulatorily what we're doing then is we are creating an equity gap. Thank you.
Thank you.
Good afternoon. My name is Michelle. I use she, her pronouns, and I'm a citizen of the Navajo Nation. It's so great to be here, and thank you for your service today. My question would be to Andrew. And as it has been said, the Indian Health Service is one of 2 federal health centers or systems in the United States. Indian Health Service for American Indian Alaskan Natives, IHS operated, tribally operated in urban Indian clinics throughout the country. My question to you would be, you mentioned about concerns around Doxy PEP and access. For our unique system of healthcare, do you have any concerns or any foreshadowing thoughts that there could be a lack of availability of Doxy PEP in our clinics, and if there could be any resistance? And then my last question would be to the panel about culturally relevant and age-appropriate health education materials around Doxy PEP. My community is a very visual community. We like to talk with someone, not over them or down to them. And what would be a good way that you would recommend, especially to communities of color, how we would present about Doxy PEP and its importance? So that's my question.
So I'll take the first part of that question. So for IHS, I don't foresee any large hurdles coming up. Our chief ID consultant, Dr. Iralu, and I have been in constant communication. So Doxy is already on our national core formulary. So access to the medication, at least, won't be too much of an issue. I think going back to where I started with awareness and providing that education to providers who may not be aware of Doxy PEP right now is what we're really focusing on, so that it's not a surprise when that memo goes out and that everyone is aware once we are able to provide the services. I think for Indian country, with syphilis at least, congenital syphilis is quite concerning compared to primary and secondary syphilis. And unfortunately with Doxy PEP right now, we cannot use Doxy with pregnant people in their second and third trimesters. And so I'm hoping that maybe someday that can change, but at least right now, that population won't be included in the rollout.
And what I'd like to add as a FQHC, having a 340B program, that's actually going to be very helpful in using that program to actually get as FQHCs, you actually have a better advantage, in my opinion, than some other agencies and even health departments where, because of the program, you're able to actually provide that medication. We know there's some FQHCs that are actually giving the medications, and because of the 340B program. So definitely, if you don't have a 340B program in place, get a 340B program. That's going to actually help you to actually get the medication out to your clients.
Yeah, and I would say, doxycycline is one of the least expensive, most used antibiotics. So, most clinics are, stock it for lots of different indications. Many clinicians are familiar with on how to prescribe it. I think there are some unique, issues. We heard that one about the prescription for one pill with, 11 refills. There are some educational needs out there for how to prescribe it for this indication, but I'm not thinking that access is going to be a substantial problem within the clinical settings. Now, obviously, people have challenges accessing clinics, but once people can get to a clinic, they should have that available. But I might be here on stage next year eating those words.
Would y'all like to see us back? Michelle, I got a comment for you. Just because your name is Michelle, I feel like we are bonded here. When you talked about the cultural competence piece, I think that goes back to some things that have been said earlier, and also how you engage the community to know what cultural competence is for that community. Oftentimes, I think as an industry, we've had the misfortunate misstep of rolling out something without getting those kind of comments, and we knew it was wrong when people just really, really pushed back. So having conversations to say, what does this look like? What resonates? What is appropriate? And I like that when you said we have a special community, and I think that if we use the approach with all of the communities that we were serving and thinking about what is going to be special and what will resonate with that particular community, instead of just rolling out something for the masses that is not received and gives people pause. So thank you for bringing that up.
Yeah, I would just add, it's cultural humility, and it's really not a one-size-fits-all approach in campaign and messaging. It really has to be local and community-driven with everyone in it together. So thank you.
Hi, everyone. My name is Joshua O'Neill. I use he, him pronouns. I'm the director of Fulton County Board of Health's Sexual Health and Drug User Health Program. Fulton County is Atlanta, Georgia. Basically, it's the biggest county in Atlanta. And if you don't mind, I wouldn't mind taking a moment to share our integration. So we offer Doxy PEP. And full disclosure to folks in the room, I've been using Doxy PEP for almost a decade. And it's been almost a decade since I've had an infection. So I can admit that it works for some people. And I also think it's really important to be transparent as a queer person, as a former sex worker, as a kinky person, as a poly person, the ways that we show up authentically in this space, and we're also honest about our experiences, because I'm one of the people that you see the data on, like on a regular basis at these conferences, and so I appreciate you hearing from me. So we rolled out Doxy PEP, but the process to Doxy PEP really was a data collection back in the fall of last year where we were doing a sexual health survey with folks at some of our Pride, the Black Pride, as well as Atlanta's Pride it's a sexual health survey asking questions about MPOX, U equals U, and Doxy PEP knowledge. We did find that some people were taking it as not as prescribed, but as a preventative thing. It also was an opportunity in that question to do some awareness, so people would then ask the health educator they were having this question with, like, oh, well, what is this about, and can you tell me more? So we got an opportunity to kind of plug Doxy PEP at that point. We're also using a platform called stophivatl.org, where you can see that we do stories about it. In fact, if you look it up on Instagram, even on Twitter, you'll see a video that we created, including yourself, or yours truly, describing what Doxy PEP is. But most importantly, what we did is we recognized that there was a lack of course, Black and brown folks that were represented in the data of people who have been taking it. And so we have already contracts with people for HIV testing with CBO partners in Atlanta, Georgia, who center and serve queer and trans Black and brown folks. And those are the folks that they trust the most, that they access services with. And so we started initially by sharing our protocols, not internally, both with our Ryan White program and our PrEP program, and our STI, like our sexual health clinic, but also with the CBO partners that we serve. I'm going to shout out two of them, Thrive SS and A Vision for Hope, are two like major nonprofit like CBOs that are doing amazing work in Atlanta, Georgia, and they deserve to be visible and heard about. And so their clinicians and their staff are actually taking this information and translating it into their own sort of language, into their own approach by their own people, so that it's a connection where people trust. So it's a way that we've sort of engaged with communities that experience these sexual health disparities so that they feel like they're getting a message from someone where it's familiar, as well as ensuring that their clinical capacity has the ability to use our protocols to offer Doxy PEP. So thank you, and thanks to everybody in the room who's considering it. I highly encourage it. It's going to be a major deal for all of us that are impacted by STIs. Thanks.
Joshua, you have to stay. Thank you for sharing what your agency is doing. Thank you for also authentically sharing of yourself. You did not have to do that, so thank you. And also, Joshua's comments and presentation represents the other reason why we come to the conference, to learn from each other. So when you hear things like this, you go, how do I connect with this person? How do I find out? And then you can also hear about like challenges. So thank you so much for sharing.
Hi, everyone. My name is Caroline. I'm a PrEP nurse at Baltimore City Health Department. And my question starts out as something that seems like it's kind of in the weeds and technical, but it has sort of implications for rollout, access, equity, everything we've been talking about. So you mentioned that you kind of roll in Doxy PEP with PrEP patients. Have you implemented Doxy PEP with people who aren't in continuity programs, and what do those follow-up visits look like? And the reason I ask that is because it came up with our staff about people who are on Doxy PEP need to come back. When do they come back? How many pills do they get? And it wasn't clear at the staff meeting why providers were so concerned about this, but I think that it has something to do with gatekeeping and sort of a patronizing attitude towards sexual health. So I just wondered if you could speak on follow-ups from a technical aspect, and then on what we can do, similar piggybacking on the person who talked about kind of demedicalizing Doxy PEP and other interventions, and just wondering if anyone could speak on that. Thank you.
Yes, so we totally have patients that are not PrEP patients and are on Doxy PEP. Because we're a full STI clinic that does PrEP, all STI stuffs, HIV, and whatnot. So as opposed to, let's say on PrEP, we will give extensions, but our HIV incidence, let's say, is so high, I care for them to have an HIV test, and that's why I ask the PrEP patients for us to come back. With STI, with Doxy PEP, it's the same, that I want to get STI testing in screening. I would not be as strict about it as I am with PrEP, because of the concern with, a breakthrough infection of HIV versus an asymptomatic STI on Doxy PEP. It would be less concerning, but the reason is to have STI screening to make sure that we're not getting, because it isn't 100%, so to make sure that we are testing and treating those STIs.
And do you
Yeah,
ask
so I mean,
people-
generally, I refuse to hold people hostage to prescriptions or renewals. So, I'll give people 1 to 2 years worth in terms of, opportunity. And, even with, my patients I treat for, HIV, I mean, ideally they need to come back on a, frequency that, meets their needs. But, some people come back once a year, and then, our clinic protocol have been, do not renew medication if they don't come back on a 12-month basis, but I think that's holding people hostage. So I think, I talk to them and encourage them to come back, but I'm going to keep prescribing their HIV medication and, hope they come back. So similarly with doxycycline, people need it. If they use it, that means they're, at risk and they're utilizing their medication. So I'm not going to require them to come back for testing so they can get their medication.
Okay. I had one more follow-up. Do you think there's any utility, or do you ask about the instances of unprotected sex at their follow-up visits in terms of usage?
I do ask usage. That's more out of curiosity. Being that we're rolling it out, I'm really curious to see how much it's actually being used, and kind of like everyone's again talking about antimicrobial resistance. So I'm using it in terms of data to see how much it's actually being utilized, but not in terms of how much I'm giving. It's the same for everybody.
Okay. Thank you so much.
Thank you.
Hello, name's Jalen Marshall. I'm one of the disease intervention specialists at the Cobb and Douglas Department of Public Health in Georgia. My question, because I know a comment was said that we shouldn't wait for CDC guidelines. That is a little difficult in Georgia for a lot of our public health departments. A lot of our conversations, or a lot of things I hear from leadership is that, well, CDC hasn't made guidelines. So we kind of stopped the conversation there, and it seems like, it feels like we're going against colleagues, going against our bosses, going against our mentors, if we do want to, jump ahead of the cart. So my question to you would be, what are some things that you're hearing from CDC that they're saying that's making them work slower or not push out the guidelines as fast enough? And what are some suggestions for our public health departments in Georgia that may help push this faster?
Yeah, I don't know if Leandro is here. He told me he might come by today or might have to go back. But, I mean, we should ask CDC. Is there CDC folks in the room? I mean, maybe they don't want to stand up and speak up, but, let's give them 10 seconds to see if they want to say.
I mean, I don't work for CDC, but IHS was asked to provide comment from CDC regarding the Doxy PEP guidelines a couple weeks ago. So I can at least tell you that's happening. Yeah.
No, I mean, I can tell you it's a very long bureaucratic process. And they could simply write a Dear Colleague letter, which can be executed and disseminated quickly. But they went, through the guidelines and recommendations route, and the federal government has very detailed and prolonged review processes that have to go through multiple agencies before things will be released. And it was only last week that the CDC came out with guidelines for indoor air quality. We knew that was a problem for a long, long time, that the indoor air quality issues were driving, COVID spread. And, it just came out last week. So, waiting for CDC to come out with guidelines, I think is a disservice to the, people we're serving and trying to help. And I think that's manifest by what they've done in Detroit, in Alameda, Oakland, San Francisco, state of California, parts of Atlanta, and other places where they've already implemented. And it's incumbent upon NCSD, which is a private, nonprofit organization, to take the leadership to move forward if CDC, because of the bureaucracy, just cannot implement.
Thank you.
So don't go, Jalen. David Harvey, did you want to jump in?
Done.
That's what
I think it's a great idea.
Clap it up.
For our panel members here, I hope you'll help us develop those guidelines.
Okay. So Pepsi challenge accepted and then thrown back. Panelists, do you accept? So Jalen, I want to say something to you because I have some familiarity with your region. And so one softer launch may be a pilot opportunity. There are certainly community-based organizations that work very well with your clinic and specifically your your district health director, Dr. Memark. And there may be some interest in having conversations to see what that looks like. So I think we should follow up for further conversations since you asked specific to your area. But I think the call to action and the response has been heard. And it sounds like you're looking at a bit of a work group, if I heard David Harvey correctly, on the panelists assisting. Is that what I heard? All right. Thank you, Jalen, for giving us something to do.
Thank you.
Hey everyone, my name is Christopher Lee. I'm a interventionist with Public Health Madison, Dane County. My question is a lot easier, but a little complex. I was wondering if anyone knew the exact science behind Doxy PEP in women and why it doesn't necessarily work in cisgender women, and if you all had prescribed to any women in your practices or even trans men.
So the study that came out recently at CROI was in Kenya, and these were women who were on PrEP. And there was no there was no change in STI and placebo versus the group. There's now, following up with that study, is why is this? Was it adherence? I don't think so. These people were already on PrEP. They were already taking a daily medication. There was discussion, is this in chlamydia in a cisgender woman going up to the cervix maybe 72 hours is just too long, and maybe it goes up so much quicker. So there's all these discussions. We don't know why yet. I am not giving it to cisgender women at this time. I would be curious if anybody else is. I am not. There is no data to show that it's working.
Okay, thank you.
Thank you.
Yeah, so I mean, they did actually biological studies where they gave women observed doses of doxycycline and then did swab measurements of the doxycycline in cervical tissue, did biopsies of the cervix to measure doxycycline, and found actually decent levels of doxycycline in those experiments where people observed and took the medication. So it's a big unanswered question, and research continues. Is it adherence? Is it something unique about exposure to the infection? And the bottom line is we don't know, and that's why we do the science to be able to prove that things work or don't work.
Thank you.
Thanks.
So I have to make a studio announcement. Due to other taping, the questions that we now have will be the last questions. So Mr. Phillips, we'll stop with you. I have to close it for questions from the studio audience. Were you in line? Now we will stop with you. Tell me your name. Richard. Richard is the last question, and then we'll let the panel close us out. Thank you so much.
Hi, my name is Dorothy Mann. I'm from Philadelphia. I'm a consultant to NCSD. So about, I want to say 15 years ago, maybe it's a little bit longer, I'm not sure, I was running a large family planning program in the city of Philadelphia. And along comes something called emergency contraception. And some of the challenges I'm hearing you deal with, we dealt with then in terms of who should get emergency contraception. Plan B the morning after, all confused with mifepristone, but we're not going to go there politically, so no. So a bunch of my colleagues started to hand this out, but they had all kinds of protocols about who's likely to have unprotected sex and therefore need emergency contraception. This is before all of the, but many of our patients had IUDs, but not as many as now. And I made a decision at that moment to stop doing that, to try to determine risk or to try to determine who was appropriate or any of that. We gave emergency contraception to everyone that came to a family planning clinic. And we did it prophylactically. They walked out of the clinic having emergency contraception in their hands. We only, the limit on the dosage had to do with money, how much we had to spend. We didn't send anybody to a pharmacy. We didn't try to do anything different. Everybody got it. And we didn't ask if we wanted it. You may not use it. Okay, fine. But everyone was getting it. Just in case you had unprotected sex and you needed to take this within 72 hours, we gave the instructions. We gave everybody in a bag with the information. And if they didn't want it and they thought somebody, their neighbor or their friend might need it, that would be fine too. We didn't give a hoot. The fact of the matter is that it was unbelievably effective. People could control this themselves. They had access to something to prevent them from getting pregnant if they had unprotected sex. Well, what in heaven's name is getting in the way of you guys doing something like that?
So Dorothy, quick question. I mean, presumably you could have given it to every male as well who had, female partners. So you
Absolutely.
gave it to everyone, males and females.
Yes. Now, maybe in this situation, until you get the science right, maybe it's not to females, or if you did, you could say we're not sure this will work, we don't have the data yet, or something like that. Obviously, you have some education to do. But we didn't have to depend on pharmacies. We didn't have to do protocol. I mean, we did have protocols. Let's give it to everybody. And it just seems to me that sometimes we get in our own way. And let's get out of our own way and let people get what they need.
All right, David, we should add her to the committee, please.
We need a second.
Harold Phillips from the White House. It's difficult to follow the great and wise Dorothy Mann, but I'm going to give it a try. As Andrew said, CDC is working on the guidelines. As Dr. Kay said, it is a bureaucratic process. And the guidelines more than likely are going to follow sort of the science and what we know. That's what CDC does. But I think that you all have a lot of experts who are already doing this. And I really do like the idea of NCSD pulling together some experts to sort of put out there some of the best practices and how to do this. I also love what Dorothy said about how do we try to deal with the problems of access. Because what the CDC guidelines are not going to tell us is how to deal with some of the problems that you all mentioned about equity, inclusion, cultural appropriateness, and cultural humility. And I think as part of STD Engage, I really encourage everyone not to wait, to have these conversations now, to begin to pull the community together to figure out what's the best way to roll this out. Because that's not going to be any different from what the CDC is going to say, and the CDC is not going to tell you how to do that. But we all know it's an issue and a problem that we got to tackle now. We're already seeing the disparity emerge. So my comment from the White House is don't wait, start now. The CDC guidance will come out. It will provide you sort of the clinical guidelines and the expertise, but some of these issues that we've talked about go beyond sort of just clinically how do we do it. Thank you.
Hi, everyone. Thank you for a great presentation, great conversation. My name is Richard Cotronio, and I'm from New York State Department of Health. And over the last 5 years, I've had the opportunity to lead up PrEP awareness campaigns, including PrEP Aware Week, which is something where we spend an entire week working with ambassadors from around the state talking about PrEP. And we've included messages about PEP for HIV as well. And what we've consistently seen is that communities have some confusion when we use the word PrEP and when we use the word PEP. And folks are continually trying to figure out which one we're talking about. And we've seen even among our ambassadors confusion. So I'm wondering, when you think about marketing this, what we're calling now Doxy PEP, is there a benefit to that? Is that potentially going to add more confusion? What do you think about Doxy for STIs? Like, I think we should really think in this nascent stage how we want to message this so we avoid the kind of confusion that we've seen between PrEP and PEP for HIV. Just a thought. I'm interested in your reactions.
I'm not a marketing person, but what I explain to patients that I think has been really helpful, I'm like, this is just like the morning after pill, that you can just, you decide when you have had an exposure that you think puts you at risk for an STI, that's when you take it. So I do agree there is a lot of confusion in the HIV world, like in communities about HIV PrEP, HIV PEP, or NPEP. And so I think that's an interesting point on how do we do this on a big marketing level? I'm not that person, but I think on a clinical one-to-one, using the term and comparing it to morning after pill has been very helpful for patients to understand how they use it.
You know, and Richard, thank you for that comment, because yes, it can be very confusing, and that's why we're here to hear the voices from you, so then that way we could actually push that up, because we are the community that's actually putting this out there, and so we could actually make that change. And so that's, you are the voice. Let me hear everyone say, we are the voice.
We are the voice.
No. One more time, we are the voice.
We are the voice.
We have the power to make that change. So let's get past the red tape and let's move forward.
Richard, I'd love to have more conversation with you because you may be a part of the work group.
That's right.
Okay, so we've come to the time where we must thank our celebrity guests. And limited resources will not allow me to give you all cars, but you get a condom, everybody gets a condom. Thank y'all for coming out.